Good afternoon and happy Thursday. Welcome to the check-in. Cutler Center for Men's monthly webinar series, where we bring important topics to life through real talk, practical tips, and meaningful support. We truly appreciate you taking the time to join us today. Just a few items to review before we get started. In this platform, attendees do not have the option to speak through a microphone. However, you can submit a question in the chat. So our Q&A is open. We'll be taking questions at the end of our webinar, and you'll be able to get your questions answered that way. I have the pleasure of introducing our speaker for today, Dr. Randy Vince. He is an Assistant Professor of Urology and Director of Minority Men's Health here at University Hospitals. And although he's from Baltimore and he's a Ravens fan, we love him here at Cutler. Dr. Vince is guided by his personal philosophy of leadership through service. He continues to develop scalable community-based models that improve healthcare access and outcomes for patients in Northeast Ohio. Through scholarship, service, and a deep commitment to service, he aims to redefine what it means to lead in academic medicine. Our topic today is prostate cancer. Learn when to worry, when to watch, and what your real options are. And I'll now turn it over to Dr. Vince.
All right. Good afternoon. Thank you, Nicole, for the wonderful intro. It's a pleasure to be with you all today. So I titled this Prostate 101. So in general, overview of the presentation today, it's only going to be about 25 to 30 minutes, and then hopefully we'll have plenty of time for question and answer. But I just wanted to start by just building a foundation and then kind of building on that. So, with that being said, these are things that I think every man should know as it relates to their prostate and prostate health, and specifically as it relates to prostate cancer. So, I'll get going. So, as Nicole said, that won't be any ability to come off of mute or to turn your camera on, but I do invite you to put questions in the Q&A box, and then I will do my best job to be able to talk through all questions and answer any questions that you might have. So just because I'm in academic medicine, and whenever we give a talk, they make us give disclosures, so there's no conflicts of interest. So I don't have any disclosures as it relates to this presentation. And then for some of you who I haven't had the opportunity to meet before, I just want to give a quick introduction to myself. So, I'm Dr. Randy Vince Jr. I'm a urologic oncologist at University Hospitals, and my path to this position started in med school down in Louisiana at LSU, and then I did my urology training at Virginia Commonwealth, which is in Richmond, Virginia. And then I did a fellowship in urologic oncology at University of Michigan. And I also have a master's in computational medicine and bioinformatics from the University of Michigan as well. And as it relates to this talk specifically, I'm a big believer that every person, no matter where you're from, no matter your background, anything like that, you should have access to the same resources, specifically when it comes to empowering yourself to, really thrive and be healthy. And so, in addition to those other things I talked about, the Urology Care Foundation, I'm their inaugural Health Equity Fellow. So again, that's us within Cutler, we are trying to make sure that we can empower men to live their healthiest, fullest lives possible. And one of the ways that we can do that and that we know we can elevate the level of care is by having patients or our members and our community members having what we call a higher health literacy. So just doing that education on specific health topics to inform yourself because the application of knowledge is actually powerful. So these are my goals. I want to share how we diagnose and risk stratify prostate cancer. We'll review some of the numbers around prostate cancer incidence, which is just means how many men get prostate cancer, the deaths of prostate cancer as a result of prostate cancer, should I say, and then the deaths from prostate cancer disproportionately impact Black men. So we'll touch on that and then kind of go over some different things as it relates to screening and how you can apply these things or take these things into your everyday life in terms of, the healthcare and that you receive. So first and foremost, what is a prostate? I actually hear this question more often than you would think. So for us as men, the prostate is just a part of our reproductive system. So um, when we have an ejaculation as a man, there's essentially two components to it. You have the sperm and then you have everything else. And all of the rest of the fluid is there to protect the sperm and to help it get to an egg so that way it can fertilize that egg. So the prostate gland produces most of the fluid that we see when we have an ejaculation, as well as some of the nutrients. It secretes some of the nutrients that allow sperm to survive on its journey to finding the egg. So it sits right below the bladder and it sits right in front of the rectum. And if you ask any of my patients, what I commonly say, and I say this, I'm a man and myself. If you're a man and you're blessed with the gift of longevity, at some point your prostate will cause you some type of issue. And it could be just simple prostate enlargement, or it could be a relationship to prostate cancer. So, how do we diagnose prostate cancer? So, typically, there is, uh, I like to think of it as a three-part process if we're doing our job correctly. So, we'll screen with the blood test, which is the PSA. Now, the PSA, the normal range is from 0 to 4. If we have someone with an elevated PSA, that does not mean that you have prostate cancer. However, it does mean that you should see a urologist and have a more thorough evaluation because we know that, the chances of you having prostate cancer as a man as you get older increase. And so one of the ways we can kind of detect early is by doing this screening with the PSA. After you have the PSA done, as long as you don't have like any shrapnel or metal in your body, the next thing we would do is we would obtain a prostate MRI, which you can see here in the middle. The reason we do that is because, in the old days when we would do a biopsy of someone's prostate, we would just randomly biopsy areas where we thought prostate cancer was most likely to form. However, when you get an MRI, what it does is it shows us if there's any abnormal areas. And then it also, based off of the characteristics of that abnormal area on the prostate, we can say whether or not it's likely to harbor prostate cancer or not. And it gives us a target to hit when we actually do the biopsy. And then to diagnose the prostate cancer, the next step would be to do the biopsy, which you can see here on the far right. Now, this is an older picture. Some people still do this, what we call transrectal biopsy. A lot of people have moved to what we call transperineal. It's a much cleaner procedure, and where you get tissue by going directly through the skin, not going through the rectum, which is part of the colon. So if you have a diagnosis, so after we get those biopsy specimen and we send them to the lab, the pathologist will look at it under the microscope and they tell us if there's cancer or not, and if so, does it appear aggressive or not? Okay, so this is just a simple way that they look at it and to kind of summarize. So they'll give it a grade. And one and two, those are not cancerous. So anything three or higher is cancerous. And a three is very indolent, so the non-aggressive, and five is the most aggressive. So, some people may talk about things like a Gleason score. We are now moving to something that we call a grade group because it's much easier to understand. But whenever we're talking about cancer in general, it's two things we always talk about: is stage, which is where's the cancer located, and grade, which is how aggressive is the cancer when we look at it under the microscope. So if you have a higher grade, then that means it's typically more aggressive. So as we transition in terms of the diagnosis, I like to say any man, if you develop prostate cancer, you'll fall into one of two buckets. We have one bucket of men that have very clinically indolent or non-aggressive prostate cancer. And because it's non-aggressive, we don't even treat it. We just do a process, what we call active surveillance, where we just watch it. And then for the men with what we call clinically significant disease, or the men that fall in that second bucket, those are the men that if we don't treat, the cancer is aggressive enough that it could potentially spread outside of the prostate and go to other areas of their body. And so that second bucket of men, we call that clinically significant because, again, if it's not treated, it can clinically impact your health. So that's how we diagnose. Now let's talk about some of the incidents around this. And this is just how many men are getting prostate cancer. So depending on the source you look at, it's anywhere from 1 in 7 to 1 in 8 men will be diagnosed with prostate cancer in their lifetime. And every year, more than 250,000 men are being diagnosed with prostate cancer. And there are millions of men that are currently living in this country that have either been diagnosed and are survivors of prostate cancer or they're living with it. And so when we say living with it, we're talking about those men that had that very clinically indolent or non-aggressive disease that are on that active surveillance that we talked about. And that's all men. But when we look at black men, it increases in terms of the numbers. And so it's estimated that 1 in 6 black men will get diagnosed with prostate cancer in their lifetime. Now, I know when we talk about cancer in general, that's something that's very anxiety inducing. However, when it comes to prostate cancer, that doesn't necessarily need to be the case. So what we have here is this is just looking at cancer numbers across the board. So if you look here at the top, prostate cancer is the most common cancer solid organ cancer in men. So it's the most prevalent. So, to say that differently, when we look at all men and we look at all the potential cancers from different organs that you could get, prostate cancer is the highest. However, when we look down to the bottom, what we see is that when we look at the number of deaths from prostate cancer, there's a smaller percentage of men who develop prostate cancer and actually end up succumbing to that disease, if you will. So even with that being said, it's still the second most common cancer or cause of cancer death in men. So, it's like, okay, we have a small number of men who absolutely or eventually die from prostate cancer. But even with that small percentage of men, it's still a pretty high overall number, if that makes sense. And I'm gonna try to explain this a different way. So let's look at this. So this was data, and this is from 2023. What you see is that if you look at the numbers in 2023, it was close to 300,000 men were being diagnosed with prostate cancer. And while if you look at this 34,000 compared to this 300,000, it's a small percentage per se. This number is still pretty high. And so that was the second most common cause of cancer deaths behind lung cancer when it comes to men. And so when we talked about at the beginning that When we talk about Black men and how they're disproportionately impacted from prostate cancer deaths, you see it now that, with this information here on this slide, that Black men are over twice as likely to die from prostate cancer as their white counterparts. But that shouldn't necessarily be the case if we're doing our job in terms of actual screening. And so, one of the ways that we look at prostate cancer or any cancer, we look at the survival, and that is from the time you're diagnosed, what is your likelihood of surviving that diagnosis at 5 years? And what you see is that it's 100% when we talk about localized and regional. So localized is, did we catch it while it was still confined to the prostate? Yes or no? If yes, the answer is yes, then it's localized. Regional is it may have spread outside of the prostate, but it's still contained to the pelvis where the prostate is located. And so you see both of these, we have really good outcomes, and we're able to treat it appropriately. And essentially, if we catch it in these stages, 5 years later, 100% of men are still around and not succumbing to that disease. But it drops off to 34% when it's spread or metastasized to other areas of the body. So what this means is that we need to do a better job of making sure that we're getting screened for prostate cancer as men, and that if there's cancer present, that we are managing it appropriately, whether that's treatment or active surveillance. And so, again, this is just a different way of looking at it. So, again, if it's localized, it's confined to the prostate. This is the pelvis here. So, even if it's spread to some of these lymph nodes in the pelvis, it's still very treatable. And so, it's not one of those things where it has to be a death sentence. And so, forgive me, I'm going to skip past this. And I'm going to talk about why screening is so important. So, some of you, if you've had the chance to interact with me before, you know that in 2012, the recommendations for prostate cancer screening actually went away. So, the Preventative Services Task Force actually recommended against men getting screened for prostate cancer in 2012. And so, because of that, less men were being screened for prostate cancer. And so, what you can see here, and this is just a research paper, but I'll just kind of walk through this. When we talk about localized disease and we're talking about how many men are being diagnosed with localized disease, you can see that these numbers are declining. So, that means we were catching less men early. And then when we talk about regional and distant, so regional is when it's spread to those lymph nodes, or distant is when it's metastasized. You can see that there was an uptick in the regional stages on what we were doing diagnosing men, as well as the distant stage of diagnosing men. So if we look back at this slide, what it shows is that essentially because we were getting more men being diagnosed with distant stage disease, that the chances of men succumbing to that disease after that recommendation changed increased. So again, this is just to highlight the importance of why we need to be doing screenings for men with, as at the age of typically at the age of 50 or higher, because that allows us to diagnose more men with this localized disease instead of and catching it while it's confined to the prostate instead of catching it after it's already spread. Because now we're taking something that we can cure when it's localized disease to something that we just need to try to manage when it's regional or distant. And so, as a result, now our recommendation is that every man should get screened for prostate cancer. So this is something that you should definitely discuss with your primary care physician. It's not something that they'll automatically do, and that's why I said it's something that you should discuss with your primary care physician. Shortly after I got to university hospitals, I still, this kind of stands out to me. There was a patient that was referred to me because he had this frequent urination at nighttime. And he was 65, and he hadn't been screened for prostate cancer. And I would say probably about 12 years since his last PSA was drawn. And when he came to see me, I realized that he hadn't had a PSA check. So I just checked one. And 0 to 4, like we talked about before, is the normal range. And his was over 40. And then, I did a workup where I got an MRI, and the MRI showed that he likely had prostate cancer that was growing towards his rectum. Um, and, even though it was still confined to the pelvis, we were able to treat it. And, he's done well since. That disease that he has is no longer curable because it started to spread outside of the prostate. So now we're just managing it with medications rather than having it cured. So that's why I say that all men should know about this so that way they can have this discussion with their primary care physician and get that PSA checked regularly. And this should happen at least by the age of 50. So I'm in my 40s now and I get my PSA checked regularly. So you can start earlier if you want, but at least by the age of 50, you should have a PSA checked. And PSA stands for prostate specific antigen. So it's not, it's just a screening tool. So again, just because you have elevated PSA does not mean you have prostate cancer. However, our ability to catch it early increases significantly if we are obtaining these PSAs. And the other thing that I would say is, a lot of times when we talk to men, they're always like, I don't want somebody sticking their finger in my butt or anything like that. That is not necessary to screen for prostate cancer. When you go in for your annual physical and checkup, they're going to do blood work. They're checking things like your kidney function, your cholesterol levels. This is just another box that they check on that blood work to get this. So, the digital rectal exam or the finger in the butt, that's not necessary to get screened for prostate cancer. So we need to dispel that myth so a lot of people aren't hesitant to get screened for prostate cancer because that's not the case. And then lastly, when it comes to screening, as you saw from the examples I gave, this is how we detect early. And when we detect early, we know that our survival goes up significantly. All right, so just some key takeaways, and before we, kind of open this up for question and answer. So again, my opinion is that no man should die from prostate cancer. Our screening tools are really good. Our treatment tools are really good. So if we are detecting early, we have the ability to intervene and treat. And the goal is for men to be able to live as long, healthy lives as possible. And prostate cancer should not be something that shortens any man's livelihood. Then when we talked about screening, of course, like we said, that's where it all starts. So that is very vital when it comes down to decreasing the number of men who succumb to prostate cancer. We got to have the screening part. So go to the doctor, get screened, and even if your primary care doctor doesn't mention anything about PSA or prostate cancer screening, you should bring it up to them and let them know that you want to be screened for prostate cancer. Again, it's just a simple blood test. And at a minimum, at least to start. Now, after you've had it checked, a few different times, it's okay to start spreading it out a little bit, maybe every 2 years instead of once a year. But at a minimum, once when you hit 50, you should have a PSA checked once a year at a minimum. Again, if from the ages of 50 to 55, if the PSAs are being checked and there's no change in them, then maybe you can discuss spreading it out. I don't see why you would, but maybe you can discuss spreading it out to every 2 years. But my recommendation would be to have your PSA checked annually. All right. And so with that, I will stop. Nicole, do you want to do this portion before we do the question and answer?
Yes, we're actually going to go into the Q&A right now. Thank you
Okay.
so much for this great information. I hope for every man that has joined, this was valuable information. You have steps to take next for your care. For the caregivers, it definitely gave us insight in how to help the men in our lives to assist them on their health journey. So we do have a question in the chat. The first question is, do you have information about modified citrus pectin?
No.
No.
I mean, I don't know what that is. I'm sorry. I've never heard
Okay.
about citrus pectin.
I can see the our attendee that asked that question, so we will definitely try and get some information for you and follow up with you. Another question: how can spouses, family members, and friends support someone with prostate cancer?
That's a great question. So, one of the things that we don't talk about, and I should have included this in the talk, is um, prostate health in general. Our prostates for us as men are generally a reflection of our overall health. So to say that differently, if you have like a lot of inflammation or you have a illness like the flu or something like that, sometimes what we'll see is that the PSA numbers will temporarily jump up for a man who has, whatever acute illness or inflammation going on, and then it'll drop right back down. So the reason I bring that up is to say your family members, people who love you can help you or help support men with prostate cancer by encouraging them to live as healthy lives as possible, right? So the things they eat, the amount of activity they have, and I'm not saying you have to be a vegan or run a marathon or anything like that. However, being a support system to help them live as healthy a life as possible will actually impact whether they have prostate cancer and they're getting treated, or if they have prostate cancer and on that active surveillance that we talked about, it still helps significantly. And they kind of state that a little bit differently. I have a few patients of mine who were diagnosed with prostate cancer at an outside facility and transferred their care to me. And they've been on active surveillance for years. And one of the things I encouraged them to do was, just eat better and take better care of yourself. And they did. And some of these guys had areas on their prostate that looked abnormal, that, harbored cancer. And when we do that repeat MRIs, they don't even have that area anymore. So, that's why I say I think this is not just something that is my opinion. I know it definitely helps.
Another question we have is, are there sexual side effects with this diagnosis?
So, prostate cancer in general, prostate cancer itself does not impact your ability to have an erection or your libido. Um, Now, if it becomes advanced, then you may see things like blood in your semen because we talked about the prostate produces a lot of the fluid that goes in the semen. So if the prostate has a lot of present and it's starting to become advanced, then you may see that. Now, there are some sexual side effects as it relates to treatments. But that's something that, you should talk to your provider about. But there are a set of nerves that run around the prostate, and those nerves help supply essentially two things. One is muscles in the pelvis that are used for us when we are controlling our urination, and then also your ability to have an erection. So those things are very important to be taken into account whenever you have treatment. I always say if you need treatment for prostate cancer, we're aiming for a trifecta. We want you to be able to have the same sexual function after treatment as you had before. We want you to urinate the same way, if not better, than what you did before, because a lot of men who are diagnosed with prostate cancer also have enlarged prostates, which impact their urination. And then we want to cure all the cancer. So that's kind of the trifecta there.
Right. I do have a couple more questions, but to our guests, if you have any questions, please drop them in the chat. What is the biggest misunderstanding about prostate cancer?
Um, So there's two things I think. One is in terms of how we screen for prostate cancer. Like I said, a lot of men feel like somebody have to stick a finger in their butt or something like that, and that's not necessarily the case. And then for some reason, I encounter a lot of men who say, "I just don't want to know. If I have prostate cancer, I just don't want to know," and they think that for some reason, if they don't know that that would be beneficial for some reason, I don't know. I don't understand that mindset. Maybe it's because they think when they hear the word cancer that it's automatically going to be deadly. But that's not the case. As we talked about during this presentation, prostate cancer is very curable, and for there's a small percentage of men where it ends up being deadly, and we need to decrease that percentage even more. So I would say those are probably the two biggest myths that are out there in terms of screening, and then the fact that prostate cancer is deadly because it's a very when we look at all the cancers across the different spectrum, things like prostate cancer, pancreatic cancer, excuse me, not prostate, lung cancer, pancreatic cancer, those things are very deadly. Prostate cancer does not need to be.
Based on the characteristics of prostate cancer, should other family members, sons, brothers, and the male relatives in the family, should they think about getting screened earlier than the standard guidelines suggested?
Yes. So if you have a family history of prostate cancer, so I'm gonna give an example. So let's say hypothetically, we have a patient whose father was diagnosed with prostate cancer at the age of 52. I just told you that every man should, at a minimum, be screened for prostate cancer by the age of 50. Typically, if we have that family history, what we would recommend is that you start getting screened about 10 years prior to when your family member was diagnosed. So in that example I gave, if you have a father who was diagnosed with prostate cancer at 52, we should start screening again, about 10 years prior, so at the age of 42. And it's no harm in starting to screen a little bit earlier at the age of 40 if you wanted to, but at a minimum, 10 years.
Question in the chat: why not just give medicine for localized prostate cancer to all men after age 70 if it is going to affect most of us in our lifetime?
Why not give medicine to? So I think I understand what the attendee is asking. So it's like, why not just give a medication to almost prophylactically treat men for prostate cancer? And one is we don't have medications that can just cure prostate cancer. The medications we have are used in conjunction with other treatments to cure prostate cancer. Traditionally, the way that we think about it and the way that I explain it to patients is testosterone, which is the male hormone, can be used as fuel for prostate cancer cells. And so a lot of the medications that we have available are used to prevent that testosterone from acting as a fuel source for prostate cancer cells. Um, and then, as we talked about before, as it relates to over the age of 70, the screening recommendations essentially, so if you think about the average lifespan of a man, if you take all comers, life expectancy is generally like 76. Maybe, depending on where you live and, your health status, it may bump up to 82. We know from research that typically if a man is diagnosed with prostate cancer um, over the age of 70, it's not likely going to impact his livelihood. And so that's why we don't even, most men, depending, again, this is patient specific, but for a lot of men, we don't even screen after the age of 70 because the likelihood of that prostate cancer impacting your livelihood or impacting your longevity is very slim. So I hope that answers that person's question.
Right, thank you. So the last question we have: what encouragement would you give to someone newly diagnosed?
That is not a death sentence, right? Like, I mean, that's what I try to hit on with this presentation. Somebody who has newly diagnosed prostate cancer, like, let's settle the anxiety around the cancer diagnosis. Because I think anytime you hear the C word, it induces a lot of anxiety. It doesn't matter who you are. You could be think you're mentally the strongest person ever. you hear that you have cancer and it is going to impact you significantly. But what I would say is this is not a death sentence. We have a lot of very good treatments available, and be encouraged and know that, we can definitely take care of this for you. And our goal specifically as me as a provider and somebody who treats prostate cancer a lot is to, while this might be a hurdle you have to get over, we want to help you clear that hurdle and then get back to living your normal life.
Well, thank you so much again for taking the time to talk to us about prostate cancer today. Those are all the questions that we have. I am now going to turn it over to Shondale, allow him to introduce himself, tell you the role that he plays in Cutler, and how we have services that are for you.
Awesome, awesome. Thank you so much, Dr. Vince, for that amazing information. And thank you, Nicole, for facilitating. I am Shandell Barnett. I am one of the program coordinators here at the University Hospitals Cutler Center for Men. So here at Hospitals Cutler Center for Men, we make staying healthy simple, welcoming, and stress-free. So we provide a full wraparound support to help men redefine what well-being looks like today through our thoughtfulness, personalized touch points, and concierge level care at no extra cost. So listen here, enrollment is completely free for men over 18, and you don't need to be a university hospital patient to join us either. Just scan the QR code that you see right here on the screen and visit our website, learn more about us, and guess what? Sign up. Sign up with us today. And when you become a member, you get direct access to our Joe team. And that's your personal go-to guides. They're here to help you find providers, schedule appointments, navigate healthcare without confusion or stress. But we also connect with you and connect you to community resources, trusted experts, and simple, easy to understand health education. And throughout the year, we host events that bring guys together for social connection, health screenings, interactive experiences that support long term health and well being. But most importantly, UH Color Center for Men is a place where you go to belong. It's a supportive and community area where you feel respected, understood, and never navigating life alone. Think of us as your wellness wingman. And I want to thank you all so much for joining us today. And let's stay connected to each other here. Follow us at UH Color Center for Men for updates, upcoming events, and quick health insights. And don't forget here, mark your calendars. Mark your calendars for the next check-in every third Thursday of the month. Each session brings something new, so you don't want to miss out. And we look forward to seeing you next time. I'll see y'all.